So I want to talk today about cardiogenic shock. And I will start with the definition. It is defined as hypoperfusion of cardiac origin using a combination of clinical and biomarker features. Most importantly, in the current guideline, it's lactate, but also, of course, acute kidney injury, oliguria, defined as less than 30 milliliter per hour, and shock liver. So more specifically, an elevated lactate more than 2 is the backbone of the SCAI definition of true shock. True shock, which is also called classic shock, which is SCAI stage C. So how about the blood pressure? Should it be included in the definition? Well, hypotension alone, of course, does not define shock. You can see blood pressure less than 90, systolic blood pressure less than 90 in the pre-shock states or in ambulatory severe heart failure. Now, the definition used in the major shock trials included both hypoperfusion and hypotension less than 90 millimeters. So it mandated the presence of both. However, in the modern definition used by SCAI and by several papers, including the European guidelines, hypotension is not even necessary to define shock. There is this entity called normotensive shock with profound evidence of hypoperfusion and tissue hypoxia by lactate levels. So you may have somebody with a blood pressure of 100, but elevated lactate and other clinical signs of hypoperfusion. He will be in the classic shock SCAI stage C, even though the blood pressure is not reduced. So hypotension alone is not enough. And while major trials mandated hypotension along with hypoperfusion, it's hypoperfusion that's most important. And you can have hypoperfusion with normotension, the so-called normotensive shock. By the way, here, I want to just highlight one idea here. We use SBP of 90 to define hypotension in cardiogenic shock, not mean blood pressure. All the past cardiogenic shock trial and all of the 11 future ones that I reviewed use SBP, not mean blood pressure. And I will just explain why, in my opinion. You know, a hallmark of low output heart failure is narrow pulse pressure, such as, for example, 80/60. If you take 80/60 over pressure, you can have a mean blood pressure of over 65. The mean blood pressure in this case is not accounting for the poor flow and for the vascular clamping of a patient with cardiogenic shock. It will be fatally elevated by that vasoconstriction and elevated diastolic blood pressure. So using mean blood pressure will make blood pressure a poorer correlate to tissue perfusion. Conversely, in septic shock, you are vasoplegic with wide pulse pressure, and mean blood pressure accounts for the slow diastolic pressure in septic shock, and it accounts for vasoplegia, and it may be a better correlate of perfusion in septic shock. So that's why in cardiogenic shock, it's systolic blood pressure that should be used based on every single trial and study I have reviewed. In septic shock, either one is okay, but mean blood pressure has been more widely used. So patients with hypoperfusion and preserved blood pressure, what we call the normotensive shock, have increased death compared to patients with hypotension, but preserved perfusion and lactate level, the so-called pre-shock. This one here, hypotension and preserved perfusion, SCAI stage B, whereas that one is already early SCAI stage C. However, the highest mortality is in patients with hypoperfusion and hypotension, as was mandated in all shock trials. I'll give some examples of some hemodynamics we see commonly, and just to know how to classify those hemodynamics. So if you have somebody who's congested and hypotensive, but without elevated lactate, this is a pre-shock, or what's called a stage B, not shock. If you have low cardiac output, you know, cardiac index of 1.8 or low mixed venous O2, but with normal lactate, that's not enough to define hypoperfusion and shock. Hypoperfusion is not a cardiac output or SVO2 number. Hypoperfusion is cellular hypoperfusion, mainly high lactate, plus or minus oliguria, acute kidney injury, or shocked liver with ALT, AST more than 10 times normal. And, you know, I'll give you some examples. So we cath a lot of those chronic severe heart failure outpatients, and frequently they have chronically impaired hemodynamic, low cardiac index, borderline blood pressure over 90, and low mixed O2 yet normal lactate. And this is explained by the chronic adaptation of those chronic heart failure. Their tissue learn to extract more O2. Actually, the mixed venous O2 of an acute shock is higher than the mixed venous O2 of a chronic heart failure and shock, because their tissues have learned to extract more oxygen, which drives that mixed venous O2 lower, and it is a compensatory mechanism. So again, you need to have evidence of cell hypoperfusion, not just those numbers, although those numbers are prognostic markers, but they would not define shock. So again, congestion with impaired hemodynamic, whether hypotension, tachycardia, low mixed venous O2, or low cardiac output, but without elevated lactate, are consistent with a pre-shock SCAI stage B. So they may be cold and wet heart failure, but they are not in cardiogenic shock. So, and I want to highlight now, aside from the definition, always distinguish the two major categories of cardiogenic shock. You have the acute MI shock, the type 1 MI cardiogenic shock, versus the acutely decompensated chronic heart failure shock. On average, the latter patients have lower EF, lower cardiac output, higher PA pressure, and similar or low blood pressure. So they may basically have worse hemodynamic numbers and worse pressure numbers, but they have better lactate and they have better prognosis acutely, because they have a chronic adaptive cellular mechanism that allow that lactate to not be elevated or not be as elevated. And the important thing about that acutely decompensated chronic HF shock, beside the better numbers in general, it has better prognosis. Here are two studies that show those numbers. The MI shock has a mortality of 45–50%, whereas the non-MI shock has a mortality of around 26%. A little higher in some other studies, but much lower mortality than MI shock. Another idea that is important in distinguishing those two is that acute MI shock is managed with acute revascularization, whereas this is not typically necessary. Acute coronary angiography is not typically necessary in decompensated HF shock. So distinguish those two. Another thing here, that number here is very important, 45–50%. That's the classic number that you need to memorize for MI shock, 45–50%. Now, but what do we call acute MI shock? That's not always easy to delineate, because all the compensated heart failure patients with shock have high and sometimes very high troponin as a result of a type 2 MI or as a result of the myocardial injury that accompany a severe shock. So what do we call type 1 MI shock, acute MI shock? So both have high troponin and possibly very high troponin. But what distinguishes both, to make it simple in my mind, is just the EKG. That's the simple answer. If you have, in order to call it type 1 MI, in my mind, type 1 MI causing shock, it's not going to be MI with no EKG finding. It's not going to be that OM occlusion that doesn't give you much EKG findings. If you're having an MI that's causing shock, you will have a glaring EKG findings, whether it's an ST elevation MI or profound diffuse ST depression as a multivessel disease MI causing shock, or new evolving Q waves, typically with evolving ST changes. So simple acute MI shock, I define it not by troponin, but by a glaring EKG abnormality. And this is a slide that's important. In acute MI shock, all three trials, the mortality of acute MI shock is stuck in that 45–50% range that you need to remember. This is in-hospital mortality. This is the shock trial in 1999. which showed an improvement of mortality in acute MI shock with revascularization to that 45–50% range. But this was in 1999, and we're still stuck on that 45–50% range. No intervention has proven definitely to improve that 45–50% number. So after talking about definition and types of shock, cardiogenic shock, I want to describe the stages of shock. And I want to give some specifics to help you use those terms appropriately. They are becoming more and more widely used. Those are the SCAI cardiogenic shock stages. So stage B is what I described earlier as pre-shock. So you're congested, and you may have some impaired hemodynamic numbers, such as impaired blood pressure or impaired hemodynamic, invasive hemodynamic, low cardiac index, low mixed venous O2, but you have normal lactate, okay? So congestion, some abnormal hemodynamic, invasive or clinically, but normal lactate. That's stage B. Stage C, on the other hand, is you're congested, and you have cellular hypoperfusion with elevated lactate or acute kidney injury and oliguria. And often, as I described earlier, often you're hypotensive, although this is not mandatory. And stage C is characteristically treated with low to medium dose of one inotrope or one mechanical support device. And at this stage, you need to have a Swan catheter. Swan is not necessary at this stage and is not proven useful in this stage, but we believe it is useful in stage C and beyond. So what is a stage D? Stage D is stage C, but hypoperfusion does not improve then normalize with small to medium dose of one vasoactive agent and or one mechanical device. So we're requiring more than those. So we're requiring 2 or more vasoactive agent, levofed and dobutamine, for example, or you're requiring high dose of one vasoactive agent, such as levofed, or you're requiring the addition on top of inotrope of a mechanical device, or upscaling your type of mechanical device. Typically, that stage D, your lactate is deteriorating. There is a bad trajectory. It's getting worse despite upscaling therapy. Typically, it's in the range of 3 to 5 or more. Also, the patient is often, if not always in that case, anuric or severely oliguric. Stage E or extremis is a stage D that keeps deteriorating despite those interventions. So those patients are deteriorating despite high doses of multiple vasoactive agents and at least one, maybe 2 mechanical devices. They tend to be unconscious, lactate very high, they are acidotic, and they are anuric, and they may be having multiple cardiac arrests. So this is the progression of shock stages. I hope everybody understood that distinction. Again, you see patient with shock on multiple vasoactive agent or high dose of one agent or vasoactive agent and mechanical device. Those are probably stage D at this stage, but also account for the trajectory. And here is what I mean by trajectory. So take that patient in the blue box. He has a blood pressure of 80 and low cardiac index and high lactate on medium dose of norepinephrine. I would call this patient stage D. However, you have to look at the trajectory. That same patient that I called stage D because we have been needing to up-titrate norepinephrine while his hemodynamic numbers and lactate are deteriorating, that same patient with the same numbers could be close to stage C if he's actually progressing in the right direction. This is what we call the trajectory. So if his actually lactate and cardiac index were worse on higher dose of norepinephrine and now they are improving, he's getting close to stage C, and you're able to down titrate your inotrope and pressor therapy while improving the hemodynamic parameters. So he's getting close to stage C, whereas this one is a stage D. So the same numbers, different trajectory will give you different prognosis and somewhat a different classification. You know, to call it really stage C, you have to normalize based on the guidelines. You have to normalize your hemodynamics with your intervention. whether pressors and or mechanical devices. So this patient probably still not stage C, but I would call it close to stage C and certainly better prognostically than this, and will be managed differently going forward than this one, as I will explain later on. And by the way, just an idea, I mentioned low and medium dose of pressors. You know, you won't find a definite answer for what do we call low, medium, high dose, but this is just a, you know, a big guide for you, a gross guide for you. So norepinephrine, low dose is usually less than 0.1 mic per kilogram per minute. Medium is 0.1 to 0.5, and high is over 0.5. That's grossly how I classify the doses of pressor agents. And this is here the trajectory idea from the SKY consensus guidelines. So I will move on now to management. I explained the definition and I explained the stages of shock. Are there any questions regarding those? Okay, I will move on to describing the management of cardiogenic shock, and I will describe it in stepwise multiple general ideas. So the first idea is the treatment differs between the two shock categories, as I highlighted earlier. Acute type 1 MI shock requires immediate coronary angiography and reperfusion. And that's about the only intervention in cardiogenic shock that's proven in a randomized fashion to improve mortality in cardiogenic shock. Conversely, decompensated chronic HF shock, which has better acute prognosis and better acute mortality, but if it doesn't have evidence of a large type 1 MI, it does not require acute angiography and reperfusion. So that's the first idea. Another difference that I will explain a little later on is that also balloon pump. Acute MI shock tend to be less responsive to balloon pump than decompensated heart failure shock, and I will explain it later. The second idea, you will find a lot of shock algorithm, but this is a simplified algorithm that I made and that I like. It's a 4-step approach to cardiogenic shock. So the first step, which is for that pre-shock stage B, is diuresis, okay? Such as this patient, lowish blood pressure, low cardiac index, but normal lactate and preserved urination. Treat this patient with diuretics. This is a congested stage B. Now, if you're stage B, but you're not achieving a proper diuretic response, you're not achieving that aggressive diuresis that you need to achieve over 2-3 liters negative balance per day, or if you are in stage C, you're exhibiting now signs of cellular hypoperfusion, those are the cases where you need to start a small to medium dose of inotrope/vasopressor, and where you should strongly consider Swan. So this is an example of, you know, patient with those same numbers, but elevated lactate or impaired urination, or again, stage B, but he's not responding to diuretics. So those are the cases where we need to start small to medium dose ino-vasopressors. So not all shock C require mechanical circulatory support, MCS. It's a stepwise approach. I think the first step is to use a small to medium dose of inotrope vasopressor. Now, the second step, which is practically stage D, you have that those cases that are not responding to small to medium dose of inotrope vasopressor. This is when short-term mechanical circulatory support should be strongly considered, and I will explain the subcategories of those. Then the fourth step is that stage D that keeps deteriorating, and then you need to keep upscaling your mechanical circulatory support and up-titrating your inopressors. So those are the 4 stages. Not all shock, stage C, early shock, needs mechanical circulatory support. If you're responsive to small ino-vasopressor dose, there's no evidence that mechanical circulatory support will provide any benefit to those patients. Okay? The third idea, so I mentioned the first idea, revascularization for acute MI shock. The second idea is that you progress in 4 steps. But the third and most important idea to me is this, a rapid escalation. How do you progress between those 4 steps? This is not a progression on a daily basis. This is a progression on a 1 to 2 hour basis at max. So, you know, you have a stage C, he's not responding to small dose of inotrope-vasopressor. You don't wait till next day to decide to put a mechanical circulatory support. You have to upscale very quickly. So rapid escalation is a key idea in the management of any shock, but specifically cardiogenic shock. Okay, and how do you decide how to escalate? You use a clinical guidance of perfusion, blood pressure, but very importantly, Swan and lactate clearance guidance. So you keep checking your Swan parameter and lactate on a 1 to 2 hour basis, and you make a decision about upscaling. Okay. So I mentioned the MCS does not need to be initiated early in patient responsive to a small inotrope dose, but it needs to be quickly initiated within 1 to 2 hours if no early response. You need to quickly escalate. Do not wait until next day. And this is the idea of what we call shock teams. Shock teams, the idea of shock teams is to have a protocol of quick escalation. Probably the specifics of the protocol don't matter as much. You will see some protocols that insist on putting Impella early on. I don't necessarily agree with putting Impella early on, but I do agree with a quick escalation and not wait too long in your escalation process. That's the key idea. So here I explain those statements. So take into account in your decision the trajectory. In your decision making, you have to quickly escalate and take into account the trajectory. So let's take this patient again. Cardiac index 1.5, lactate of 4, on norepinephrine 0.2. This is this patient right now. Well, depending on how he was with the same numbers, if he was better, if his lactate was better on a lower dose of norepinephrine, and now he's deteriorating by Swan and lactate level, well, this patient is stage D and deteriorating, I would definitely put a mechanical device, and I would consider the stronger mechanical device in this patient, Impella, as opposed maybe to balloon pump. Conversely, you have the same patient with the same number, but his trajectory is favorable. His numbers are improving, you're down titrating his pressor requirements. Then this patient, you may put a balloon pump, or you may just wait an extra hour and see how his trajectory continues to evolve. So the idea is quick escalation and take into account the trajectory of that patient within that quick assessment. All those decisions need to be made within a short time frame. Again, not waiting until next day. That's the key idea. So here is a summary of those concepts. The main goal of shock algorithm is to escalate therapy and MCS quickly and sequentially in less than a couple of hours, guided by lactate and invasive right heart cath hemodynamic. Do not focus on one specific mechanical circulatory support, in my opinion, and except for culprit revascularization in MI shock, no one specific therapy has improved outcomes per se. Rather, it's the rapid protocol-driven escalation, which is the idea of shock teams, that improves outcomes. And here, regarding, again, to not be insistent on what specifics, although I will provide you a little later the specifics of therapy, which mechanical circulatory support you would use, which one of those, I will provide you some guidance, but I want you to know that it is subjective, and what improves outcome is the quick escalation, not the specifics of therapy. And here I learned from septic shock. It's a lesson in history. I hope everybody recognizes this trial. Septic shock has been well ahead of cardiogenic shock in terms of standardized algorithm. The first such algorithm is this landmark paper by Rivers in 2001, which established that early goal-directed therapy reduces mortality dramatically in septic shock. The main message of that algorithm, now we know over 20 years later, is that what improved outcomes was the rapid escalation in therapy in septic shock using 3 hours benchmarks. People at the time, though, however, misunderstood the algorithm. They implemented every single detail of that algorithm. They put a central line or Swan, and they tracked CVP. They tracked mixed venous O2, and they used dobutamine and aggressive red cell transfusions. We know from later trial that actually none of those specifics improves outcomes per se. 3 major trials later on in the 2010s have shown that early therapy without any of those specifics using a 3-hour benchmark has achieved similar outcomes to this early trial here. So that's the idea. You know, I hope we don't make the same mistake in cardiogenic shock as we go forward. I think the key is a proper aggressive early escalation, not necessarily the actual specific. This is one of the later trials in septic shock that showed the specifics don't matter. It's really the aggressive early therapy with pressors, with fluid and pressors, not the specific, certainly not aggressive transfusion or aggressive dobutamine. So I'll go back to cardiogenic shock after I really wanted you to learn that history lesson. We can learn a lot from septic shock. So I'm going back to cardiogenic shock. This is one of the very notorious cardiogenic shock algorithm from Detroit Initiative. They do insist on using Impella early on in acute MI shock with those parameters. But like I said, I don't personally think that's necessary as far as the Impella per se, although I think it may very well be used, but I'd like to have room for personal judgment. This is another algorithm that I like more. It's from Innova Heart Institute, where again, they use aggressive early escalation. And that early escalation consisted of the use of any mechanical circulatory support based on your judgment. Around 45% of the cases were balloon pump. The other 55% was Impella, and some of them were ECMO. But they left room for judgment in your choice of mechanical circulatory support. And they showed a significant, it's a retrospective analysis, but they did show an improvement in outcomes after implementation of this algorithm compared to the earlier era. So I find this to be, you know, a helpful algorithm, the one I showed earlier. And I will detail some of it now. So now that we know the 4 steps, now that we know the rapid escalation being key, now that we know cath in acute MI shock, I will detail some of the specifics, such as the Swan hemodynamics and which MCS to use. Okay. So Swan is critical in stage C and beyond. It mainly has actually treatment value. It may not help much in establishing the diagnosis. The diagnosis is often established clinically as cardiogenic shock, but it helps with the treatment. It helps with monitoring the therapy response, and mainly, you know, how is your cardiac index, but more than cardiac index, the mixed venous O2 and the cardiac power output. How are they evolving with therapy, and to decide about that early escalation. It also allows the assessment of RV parameter. Well, if I need to escalate, should I escalate with this time RV support device rather than just stick with escalation LV support? So you look at the RV parameter, and it very much helps with that. And as a result of those two, it helps decide which MCS to use. So it helps you track the patient and know how to up-titrate your devices. It can have a diagnostic value, mainly in a patient whose clinical picture is a septic shock picture. He has a, you know, for example, an infectious focus, he's infected, he has fever, yet he also has a background history of underlying low EF. So Swan may help you sort out how much that heart failure is contributing to his shock. Is his cardiac index okay, or it has declined and he's now at a phase of mixed cardiogenic distributive shock, low SVR and low cardiac index. So it can help in mixed shock, but it's mostly a treatment value more than a diagnostic value. Just an idea about some of the parameters we use in Swan to track therapy response and upscaling. Cardiac power output, I explained it in another talk, but cardiac power output is a better predictor of prognosis and about the necessity for therapy escalation than cardiac output. Cardiac power output integrates flow with pressure. It's cardiac output multiplied by the systemic arterial pressure. It's trying to assess the ability of the heart to generate cardiac output against peripheral vascular resistance. It is a form of energy generated by the heart into the systemic vasculature. It's not flow, it's energy. The normal cardiac power output is 1 watt, and it's considered significantly abnormal in our shock management when it's less than 0.6. And it's the strongest predictor of mortality in cardiogenic shock based on the shock registry. And it is complementary to the mixed venous O2. Mixed venous O2 assesses how well the cardiac output matches the peripheral oxygen demands. Cardiac power output assesses how well the cardiac output matches the mechanics of peripheral vascular resistance. So one assesses, the mixed venous O2 assesses how well the cardiac output matches metabolism. Cardiac power output assesses how well the cardiac output matches the mechanics, the peripheral vascular resistance. So both are very important in tracking the response to therapy. By the way, those cardiac power output and the mixed venous O2 apply for both RV and LV shock. Those are just cardiac output in general, regardless of whether it's RV or LV or both are impaired. Now, if you want to use a specific parameter for the right heart, the specific parameter for the right heart are RA pressure and how it is evolving with your therapies. And the second one is the PA pulsatility index, which is a ratio of PA pulse pressure, which assesses forward RV failure and pumping, divided by RA pressure, which is a backward RV failure. So forward failure divided by backward failure. If this number is less than 1, you have severe RV failure. So the less than 1 means the RV barely generates a pulse pressure, yet that pressure is building up backward in the RA. The third parameter, not much used, but actually there is good data for it. It's RV stroke work index. It's basically stroke volume index multiplied by the pressure generated by the RV, which is mean PA pressure minus RA pressure. Less than that is indicative of severe RV failure. So you use those parameters in deciding the mechanical circulatory support, as I will describe. Before I describe, I want to describe more details of the mechanical circulatory support. But before I go forward in the details of those devices, I just want to mention pitfalls of all of them combined. So one, none of them has shown in any randomized fashion to improve outcomes in cardiogenic shock. The one most largely studied is the balloon pump in acute MI, the IABP shock 2 trial, and balloon pump failed to improve outcome in acute MI shock in a large fashion. There is another trial, small, IMPRESS. It's called IMPRESS randomized trial. It was only 48 patients, and it randomized a patient with cardiogenic shock to Impella versus balloon pump. And there was no difference in mortality. The problem, they included patients who were very sick and probably who are unlikely to benefit from any intervention. There were more complications with the Impella with no benefit on mortality. But that's the only really randomized trial of Impella versus balloon pump. It's very small, but that's the only one. On the other hand, you have 3 major registry analyses published in Circulation and in JAMA that have shown increased complication and possibly mortality with Impella versus balloon pump in cardiogenic shock. I don't say that I believe that's necessarily true. There is bias, even though those are excellent analysis. They did have some bias. They are registry analysis. But all those are just for you to understand that we are far from being certain that any mechanical circulatory support improves outcomes in cardiogenic shock. We like to believe so, and it is very much integrated in any algorithm, but just know that caveat. And those caveats prevent MCS from being first-line therapy. I mean, some people have such animosity to inotrope and pressors, they want you to just try not to use them at all and just use mechanical circulatory support. There's absolutely no evidence for that. And, I would argue that a small dose of inotrope-vasopressor is probably safer than taking the risk and potential complication of mechanical circulatory support, including the vascular complications of those. So, and that's why, because of those caveats and the lack of evidence, mechanical circulatory support is hard to justify it as first-line therapy. However, they are easily a second-line therapy early on within hours if low or medium inopressor dose fails and the patient has favorable survival features. What I'm trying to say is that you have to take into account those factors. And there are multiple scores you can use. There is this CARD-CHOC score, there is IABP Shock 2 score. Those are online scores that give you an idea about what's the mortality probability of that particular patient. But what those scores use are those parameters. And what I'm trying to say here is that the more the patient has poor survival feature, the less likely you are to provide any benefit from mechanical circulatory support, the more likely it is for that MCS to be futile. And this is kind of what I absolutely love, is I made that curve. It's U-shaped benefit from MCS. It's not proven, but it's my perspective and my belief of the harm-benefit ratio of MCS. So if you're in a very early stage of shock and responsive to inotrope, you're probably more hurt than you benefit from mechanical circulatory support. Conversely, if you're in advanced stage D or E, or if you've been in stage D and you haven't escalated quickly enough and you're seeing the patient 24 hours later after the patient has been on high dose inopressors for 24 hours, you're already late. You already have multi-organ allergy for 24 hours, you're probably already late. And those patients are unlikely to benefit. In light of their very high mortality, they are unlikely to benefit from MCS. Whatever you do for them, their mortality is very high. So in my opinion, there is a soft spot for MCS where the harm-benefit ratio is favorable. It's those patients on whom you're rapidly escalating within hours of stage D or within hours of a rapidly progressive stage E. Those are the patients where I think you benefit. Again, it's within that rapid escalation strategy, early on stage D, early on stage E, not very early stage C and not very late stage D or E. And, take into account other features. So I mentioned trajectory and duration of shock. That's key idea to me. But also other known unfavorable features that are integrated in those scores and that have been highlighted in many trials and registries. Patient's age over 75. For every 10 years, your mortality probably increases about 30% in cardiogenic shock based on a Mayo registry. You can use a cutoff of 75, but as we know, it's more a linear progression. So keep that into account. Neurologic status, the patient who's unresponsive with no response to motor or voice stimuli, he has very unfavorable prognosis. Severe acidosis, baseline comorbidity, you have vascular disease, you have PAD, prior stroke, advanced CKD, and frailty. CKD is always a strong predictor of poor outcomes in shock. So take those into account. PAD will make MCS more risky, more vascular and bleeding complication in PAD patients. So you take all those into account before putting the MCS. And I think you should take that curve into account as well. Another thing is post-cardiac arrest. That's also one of the unfavorable feature in cardiogenic shock. However, probably more important than post-cardiac arrest, as has been highlighted in the recent iteration of the SKY guideline, is the neurologic status. If you've had a brief cardiac arrest and you have a good response to motor and voice stimuli, then probably your outcome is not as adverse as somebody with poorer neurologic status. So neurologic status is probably more important than post-cardiac arrest status. All right. I will describe a little bit the specifics of those mechanical circulatory support. I will give other talks in the future about those, but I will give specifics in terms of maybe which one you can choose and how to upscale. So if you have a predominant LV shock, those are the four therapy in this order of aggressiveness: balloon pump, Impella CP, Impella 5, which is surgically placed via surgical axillary access, and the last will be the VA ECMO plus LV unloading. If you have a biventricular shock, you start with those. If RV shock persists after LV improves, then you can use the 3 RV shock supportive devices that we have: Impella RP, Tandem Heart, Protect Duo device, and VA ECMO. If you have isolated RV shock, such as acute PE shock or acute RV MI shock, or RV contusion shock, you can use any of those 3 devices. Okay, so I'll detail it a little more. So for predominant LV shock, it's any of those 4. And it's a judgment call. Most often we use one of those 2 to start with, balloon pump or Impella CP. Higher pressures, higher lactate, lower CPO, lower mixed venous. We, again, subjectively, we may prefer Impella CP rather than balloon pump. Regardless, even if you choose balloon pump with those higher numbers, the key idea is upscale quickly, use lactate and Swan to guide response and upscaling, and use your trends of CPO and SVO2, again, quickly. One study, I will highlight here, used based on cardiac power index less than 0.28, so cardiac power output divided by body surface area less than 0.28, predicted failure of balloon pump and the need to escalate. So again, the worse your numbers, the more likely you are to choose Impella CP. Again, it's a subjective decision. Take into account, like I said, femoral anatomy, PAD. You always do femoral anatomy, femoral angiography before you place those devices. Take into account PAD, bleeding risk in those patients. You can start with balloon pump in some patient and change to Impella through the same access site. It is feasible to exchange from balloon pump to Impella. You remove the balloon pump over 0.18-inch wire, then advance a small dilator over 0.18-inch wire, then you place 0.035-inch wire, then the Impella sheath. But that exchange, you can have a bloody mess during that exchange, but it's feasible to upgrade from balloon pump to Impella. There are patients where you would start with ECMO, by the way. For example, you have that stage E, that quick stage E. Consider ECMO upfront, that patient who is in near cardiac arrest or who is having multiple cardiac arrest, who's requiring very high doses of multiple pressors. It's probably best to start with ECMO in that patient. So stage E, you may start with ECMO plus LV unloading. The other stages, typically, it's one of those 2. So I said, for predominant LV shock or biventricular shock, you start with one of those 4 devices, typically those 2. Now, and then you quickly follow the patient. If lactate, CPO, and mixed venous O2 and pressure requirements remain severely impaired after the first device chosen, what do you do next? If the shock persists after LV support and RV parameters are okay, or RV parameters are not okay, but you still have bad LV parameters, then you need to escalate LV support. So shock persists after LV support, but your LV parameters have not significantly improved, then you need to escalate your LV support. If, on the other hand, your LV parameters have improved, but your RV parameter remains severely impaired, this is when, and those are the RV parameter I explained earlier, this is when you need to add your LV support, RV support, rather than escalate your LV support. So this is what I mentioned, the Swan helps at this stage. It helps you measure those parameters, how they are trending, and decide, do I just need to upgrade my LV support because the wedge and the LV stroke work are still bad? Or those are okay at this point, it's the RV that's bad and I need to add RV support, whether specific RV support or a VA ECMO that will support both my RV and LV. And normally when you use VA ECMO, you need to unload. So it's nice that you have Impella or balloon pump before you put VA ECMO, because anytime you use VA ECMO, you need typically to use LV unloading with one of those. So it's okay if they are there beforehand, you keep them in and you add VA ECMO to them. I want to highlight one other idea regarding those support devices. I mentioned it earlier. Decompensated heart failure shock appears to derive more benefit from balloon pump than MI shock. And there was a very nice paper about that in European Heart Journal about 6 months ago. So intra-aortic balloon pump dramatically improves mixed venous O2, cardiac power output, and wedge pressure in decompensated HF shock based on that study. whereas the hemodynamic effect is limited in MI shock. Not just the mortality, the hemodynamic effect is limited in MI shock based on the ESAR shock trial. If you compare both those trials, the numbers were much improved in this, not much improved in this one in MI shock. Hence, maybe the lack of mortality benefit of balloon pump in MI shock. I'm just trying to superimpose multiple trials here to try to make out a conclusion. And why is that? I try to figure out why is balloon pump more useful, probably theoretically, and based on those two hemodynamic studies, in heart failure shock than MI shock. And those are the three ideas, in my opinion. Heart failure shock, chronic decompensated heart failure shock is much more afterload sensitive than MI shock, because the chronic heart failure, the LV is more dilated in that case. Hence, you have more wall stress, which equals more afterload, which equals more afterload dependence. So the chronic heart failure shock is more afterload dependent than acute MI shock, where the LV is small typically. Heart failure shock is more severely vasoconstricted than MI shock, because in MI shock, as shown in the shock trial, you can have a degree of inappropriate vasoplegia. You can have a mixture of cardiogenic and vasoplegic shock. So heart failure shock is more vasoconstricted and therefore more likely to benefit from the afterload reduction of balloon pump. Third idea is that you do get, on average, more functional MR in heart failure shock than MI shock, and IABP may be useful for that, particularly useful in patient with significant MR. That's why actually balloon pump in those decompensated heart failure, it may on occasion be considered for pre-shock stage B, even if they are not yet in full-blown shock. So this was my gross approach to how to use those support devices. A lot of subjectivity involved and a lot of use of those parameters and the trend of those parameters. So know very well what parameters to use and know how to trend them. Cardiac power output, mixed venous O2, wedge pressure, LV stroke work, and PAPI and RA pressure. I want to mention also another idea that I get asked by a resident. I mentioned a lot about MCS and I mentioned inotrope-vasopressors, but I get asked, what is, okay, which inotrope, which vasopressor? Based on those three trials, this is my approach. For blood pressure less than 80 or predominant RV failure shock, it's norepinephrine, not dopamine, based on that SOAP2 trial, which took septic and cardiogenic shock. But in the cardiogenic shock subgroup, norepinephrine had better survival than dopamine. Also, in all groups, norepinephrine has less arrhythmia than dopamine. So SBP less than 80 or predominant RV failure shock, it's norepinephrine. SBP more than 80 is dobutamine or Mirinon. If you use Mirinon, Mirinon has hypotensive effects. So do not use a bolus and start low drip, then up titrate slowly. There was a study, the Doremi study published last year, dobutamine versus Mirinon in cardiogenic shock. There was no difference in outcomes. There was a study of, I get asked, how about epinephrine? Well, there was a study in 2018, epinephrine versus norepinephrine in cardiogenic shock. Epinephrine was associated with more refractory shock, tachycardia, and lactic acidosis than norepinephrine. Hence, my preference for norepinephrine. I want to take a step back now. I explained cardiogenic shock in a lot of details, but I want to take a step back and try to manage the patient presenting with any shock of any sort before deciding it's cardiogenic. Remember, the patient doesn't walk to you and tell you I have cardiogenic shock. You have to figure it out. So how do I approach any shock? And I think also a cardiologist should be good in managing any shock, including understanding the septic shock algorithm. So here is a general approach. You have, as you all know, there are four big categories of shock: septic, cardiogenic, obstructive, as in tamponade, massive PE, and hypovolemic hemorrhagic. But two big ones. And I want to explain, how do you approach that patient? SBP less than 90 and hypoperfusion. How do you quickly approach him early on? The big question I use early on, should we or should we not give him fluid? That's the first big question you ask yourself. and you're seeing the patient quickly, you want to get quick clinical answer. I look at this on exam. There are a couple of things that help me early on: fever and congestion. Most importantly, congestion. Does he have elevated JVP, or does he have a JVD in an upright position? That's congested. Does he have peripheral edema, which oftentimes in a shock patient implies he is hypervolemic and congested? And does he have pulmonary edema on X-ray? Another thing, if you cannot, not everybody is very good in assessing JVP, what I suggest, just make the patient lie flat. So if he doesn't have JVD in an upright position, or you cannot measure the JVP, just put him in a flat position and see, do you distend his jugular vein? If you don't get any jugular venous distension in a flat position, odds are he's not congested. This is just a quick, not always very accurate, but fairly quick way of assessing for congestion. So if he's not congested, and I use those idea of congestion to decide, if he's not congested, then I start with a fluid bolus in less than an hour, as in the sepsis guidelines, 1 to 2 liters in less than an hour. Then he's not responding within that hour to that 1 to 2 liters, I start norepinephrine. If he's congested, start norepinephrine upfront rather than fluid. You know, I take into, so again, biggest thing to me, assessing congestion quickly. Fever is very useful. White count, focal infection site are useful. Of course, history of heart failure, low EF, and EKG, evidently. But the big ones to me are congestion and fever in that very early on, those first 2-3 minutes, okay? Then as you're doing that early resuscitation, get a bedside echo, and it will help you in management. But there are some caveats, as I will describe here. So I will give you an example here. This is a patient, again, 65 years old, low pressure of 80, oliguric, obtended, so he's in shock. He has a history of EF 30%. But I'm looking at him, he's not congested. He seems in shock, but he's not congested. His JVP is normal, no peripheral edema. He has a temperature 101, white count 21, chest X-ray shows what seems like pneumonia, maybe some superimposed heart failure. He has old Q waves on the EKG. So does this patient have septic shock, or does he have cardiogenic chronic heart failure shock? If it is septic shock, should you give fluids? So here's my take on this. I think, you know, he has septic shock. He's not congested. He has fever, a high white count. Although he has an underlying chronic low EF, he's presenting with septic shock, maybe from pneumonia. Now, if it is septic shock, should you give fluids? So here is my answer to this. During septic shock, LV must, in any patient with septic shock, the LV must increase its output to fill the massively dilated circulation, low after load, and to compensate for the maldistribution of flow, including a maldistribution of flow into the venous capacitance. So when you have underlying heart failure, you have limited cardiac output reserve, and the cardiac output cannot rise appropriately. So it's easier to be in shock when you have pneumonia and fever if you have underlying low EF than if you don't. That said, it's still a septic shock. The primary driver is that infection. It's vasoplegia. It's facilitated by the heart that's not able to compensate and fill that massive circulation, okay? So it's what we call a primarily septic shock with a secondary cardiac component. So in those patients, cardiac output may be normal or low normal. Again, this because cardiac output is not the driver of shock, but it's inappropriate for the vasoplegia of the patient. So the way I manage those patients, no need for LV device, usually, but avoid the standard aggressive early fluid resuscitation of the guidelines, those 2-3 liters, and may rather treat straight away with inopressors and diuretics, okay? If they are not congested, maybe you can give a little fluid, but certainly less than what's recommended, maybe 500 milliliter, but certainly a much lesser amount. So you manage them as septic shock, except with very careful fluid, and maybe no fluid at all, just go straight with pressors, okay? And Swan may help in those mixed cases. If you're not sure of your diagnosis, does he have a cardiogenic component? And the Swan will show you, is his shock mainly low SVR, or he has low SVR, but he also has a low cardiac output, meaning he has a clear-cut cardiogenic component. So the degree of cardiac output decline will tell you whether there is a clear-cut cardiogenic component that may require support device or specific inotropes versus just a pure septic shock therapy. If the cardiac output is in a normal, low normal range, you don't need a specific, probably, cardiac therapy. You just focus on septic shock therapy and vasoplegia therapy, treatment of vasoplegia, basically. So this is why I mentioned do bedside echo. It will help assess your shock, but there are some caveats to it. There is a second caveat of that echo. I'm going to give you another case scenario very similar to this one. So 65-year-old, hypotensive, in shock, oliguric, obtended, no cardiac history. I had normal echo 2 months ago, not congested clinically. He also has fever and white count. So it looks like a septic shock picture from pneumonia as well. The interesting thing, though, you did an echo on him and you see a newly declined EF of 35%, globally declined EF. So now you're asking yourself, is this septic shock or is it cardiogenic shock? And again, same question, if septic shock, should you give fluid? This scenario is extremely common. There was a septic shock patient with newly low EF. Regardless of prior cardiac history, septic shock is commonly associated with a secondary septic cardiomyopathy. It's 10 to 15% prevalence, cytokines mediated. So EF here is declining secondarily to sepsis and improves within a few days. This is not a low EF that is driving the shock. It may eventually start contributing to the shock, but it's secondary to sepsis. It's not the driver, the primary driver of the shock. It is secondary to the cytokines, particularly TNF alpha. It's actually sometimes secondary to that aggressive early fluid resuscitation. When you give patient aggressive fluid in septic shock, we know that LV poorly tolerates acute volume overload, especially in patient who has some underlying structural heart disease, even with a normal EF, but some underlying heart disease, they may not tolerate that aggressive volume overload. So that declining EF could be secondary, is in this case secondary to septic shock itself or the aggressive fluid resuscitation. It's not the primary driver of shock. Management is similar to what I described here. It's mainly focused on vasopressor and septic shock therapy, usually without the requirement for any LV support device. Rarely, if the cardiac output is profoundly reduced, less than 1.5 to 2, that's why Swan can help you in those mixed cases of septic shock and some cardiac component by echo or by history of low EF. And if the cardiac output is profoundly reduced, particularly in cases where you have associated myocarditis on top of the septic shock, as we've seen in the COVID era. So in those patients with mixed septic and truly severe cardiogenic shock with an absolute, not just relative reduction in cardiac index, an absolute reduction. So cardiac index is not just inappropriate, it's very low in absolute, less than 2, then LV support may be needed. Balloon pump is generally less helpful in those mixed septic cardiogenic shock. If, again, most often you don't need any support, but if you ever need one, I think balloon pump is less helpful as afterload is generally reduced in this mixed shock. All right, I have one more idea I want to describe and I'll be done. Again, as cardiologists, you need to know the management of septic shock, including, isolated septic shock. Because a lot of time you don't know what the patient is, you're taking care of him, you admit him to your service, and he turns out to be septic shock from pneumonia or from UTI. So how do you manage septic shock? This is the algorithm of septic shock that I have in my book that is inspired by many of those early aggressive septic shock therapy. And I want to highlight septic shock management is focused on 3 ideas. One, Swan is usually not needed in septic shock. It can be needed in those mixed septic, cardiogenic, unclear picture shock, as I implied, but overwhelmingly in septic shock, Swan is not indicated. Actually, this is based on ARS-NET trial, French PAC trial, and PAC-MAN trials. All 3 major New England trials have shown no benefit of Swan in septic shock or ARS or medically ill patients. So no Swan usually. It has to be clinical guidance. And clinically, you use 3 ideas in resuscitation. One is fluid resuscitation, aggressive fluids early on, 1 to 2, usually 2 liters within 1 hour, not if they are congested. And you start pressors within the first hours after the first 1 to 2 liters of fluid. You start it within the first hours after 1 to 2 liters of fluids, then vasopressors early on within the first hour. Then the third idea here is, the third frontier in management of septic shock is the assessment of dynamic parameter of fluid responsiveness. And you need to know that. So after the first 2 liters of fluid and after starting vasopressors, you need to assess whether the patient is still in shock. Should I give more fluids or should I up titrate my pressors? And the way you decide that beyond those first 2 liters is those dynamic parameter of fluid responsiveness. Of course, if you're congested at this point, you should not give more fluids. But assuming you're not congested yet, should you give more fluids or should you up titrate vasopressors? Dynamic parameter of fluid responsiveness. And here are those parameters. I really think cardiologists should know that. What they are is basically, you're trying to see if you give fluid to that patient, is his cardiac output going to rise? Is his tissue perfusion going to improve? So the way we assess that is, one, theoretically can give the patient 500 milliliter bolus of fluid and see what happens to his cardiac output if he has a Swan, or what happens to his pulse pressure. So rather than giving the patient fluid and seeing what happened, the better way is to assess stroke volume change using 2 maneuvers. The more important one to me is passive leg raise. So the best thing to do is you raise the patient's legs for about 30 to 90 seconds passively. You hold his legs up and you measure by echo the aortic VTI before you raise his legs and after he raises his legs. If by echo, the point of care echo, if your aortic VTI is rising more than 15%, you're responsive to the increased preload and you're going to respond to giving more fluids. You can also assess with passive leg raise, instead of using aortic VTI, you can use pulse pressure on the arterial, on the arterial line. Typically, those patients with septic shock, most of them should have an arterial line. And so you do passive leg raise and you see what's happening to the pulse pressure on the arterial line. The pulse pressure goes from this to that, not that dramatically necessarily. It goes more than 15%. Then you're fluid responsive and you can give the patient another bolus of 500 milliliter, then keep reassessing. After every bolus, you reassess those parameter of fluid responsiveness. So passive leg raise and assess aortic VTI or pulse pressure. I do it regularly in the ICU. I love that. Passive leg raise, pulse pressure. I do it very regularly. You can use, instead of passive leg raise, if the patient is ventilated, you can use a change between inspiration and expiration and pulse pressure. Okay, the delta inspiration, expiration, and pulse pressure. Again, more than 15%. If you remember, one number is 15%. The best for me, passive leg raise, pulse pressure change on the arterial line. And this idea relies on of course, on the Starling curve. You increase the preload, you get an increase in cardiac output in this stage. You increase the preload here, you're not going to get an increase in cardiac output. The patient here is not volume responsive. The patient here is volume responsive. It's the Starling curve. Preload dependence. I will stop here.